Hello, my name's Dr. Robert Fawcett, and the program we have for you today is called Calming the Bipolar Storm. It should be especially helpful for persons that have bipolar disorder and for their family and friends, but really for anyone who wants to learn more about bipolar mood disorder. And even healthcare professionals are likely to learn some new facts about bipolar disorder from this program. Let me tell you a little more about my background. I got most of my higher education in Michigan. I went to Michigan State as an undergraduate and then Wayne State for my medical training, and then finally the University of Michigan for my psychiatry residency. And I'm board certified in general adult psychiatry. I practiced throughout my career in northern Michigan, and some of those years I served as medical director of the inpatient services and partial hospital services at Northern Michigan Hospital, what is now referred to as McLaren Northern Michigan in Petoskey. A few years there, I was an assistant clinical professor at Michigan State University College of Human Medicine when we were helping to teach medical students who rotated through the hospital. I've been a past psychiatric consultant at North Country Community Mental Health and Northern Lakes Community Mental Health. I had an outpatient practice for 38 years. There's certain advantages to being in one spot for a long time like that. You get to see patients over a good length of time and see how things develop and progress for them and for their illness. I also sometimes would see 3 generations of family members affected by bipolar mood disorder. So that has given me a unique perspective that many mental health professionals probably don't have. And through the years, I've had some publications in a number of scientific journals, the ones listed there and a few others. And then in 2021, I published a book called Calming the Bipolar Storm, a guide for patients and their families. Presumably you may recognize Ernest Hemingway. He got the Nobel Prize in Literature, and he was a denizen of northern Michigan. In fact, I've sat at the same bar at the City Park Grill that Ernest Hemingway used to sit at. But Ernest Hemingway suffered from a bipolar mood disorder in his adult life, along with alcoholism. And many of the issues that he struggled with in his life are issues that he would have in common with many people that have a bipolar mood disorder. There's been more visibility of bipolar disorder in the media. Movies like Silver Linings Playbook have characters with bipolar disorder. TV series like Homeland, The Big C, or one of my current favorites, Ozark. In the world of music, Nirvana had Kurt Cobain. Mariah Carey announced that she had a bipolar II mood disorder. Jimi Hendrix even wrote a song called Manic Depression. There have been autobiographies by persons with bipolar disorder of famous people, Patty Duke, Jane Pauley, and Carrie Fisher. My own favorite such autobiography is An Unquiet Mind, written by Kay Redfield Jamison. Dr. Jamison not only has a bipolar I mood disorder herself, but she's also a world authority on bipolar disorder. So she can talk about it from both those perspectives. Some of the goals for our presentation today are to describe bipolar disorder, talk about its causes and its course through time, And we're also going to talk about how a person can set a healthy baseline for themselves that promotes mood stability and reduces relapses into depression or high spells. And talk about 8 ways to help calm the bipolar storm. What is bipolar disorder? Well, at one level, it's a disorder of mood and energy. Persons can sometimes soar into a high mood where they feel very euphoric and optimistic, sometimes grandiose, and they may have lots of energy. They may be able to go for days at a time with very little sleep. Sometimes they're moving and talking rapidly. But then also they encounter the flip side where they fall into a depression where they have a very low, sad, pessimistic mood and their energy level is extremely low. It may be a struggle just to get out of bed and do anything. This is a picture of Dr. Emil Kraepelin. He was a German psychiatrist who coined the term manic depression back in 1899 in one of his textbooks. And his conception of manic depressive illness is a little different from our conception of bipolar disorder today, especially in the sense that Dr. Kraepelin also included persons who have recurrent major depression as part of the manic depression spectrum, persons who don't have any high episodes at all, but just have multiple recurrent depressions. Here's another German psychiatrist, Dr. Karl Leonard, who in 1957 coined the term bipolar disorder. He was splitting the manic depressive realm that Dr. Kraepelin had defined into those bipolar persons who had the high mood swings and the low depressed mood swings, and separating them from what he called monopolar depression, people who just had the recurring depression swings. And the term bipolar disorder caught on across the world and was incorporated by the American Psychiatric Association into their official diagnostic nomenclature. When we talk about bipolar disorder, we first need to define some other terms. Mania. Mania refers to a mood that's a change from the person's usual mood. Their mood becomes abnormally elevated, maybe euphoric and expansive, or sometimes irritable. Often what we see is a kind of euphoric mood, but then when you obstruct the person's attempt to reach certain goals, they become very irritable. Usually they have goal-directed activity, increased goal-directed activity. They may be moving more rapidly and doing things or talking more rapidly. Ernest Hemingway had a stretch where he was in a more manic mood and wrote 5 short stories in a very brief period of time. Sometimes this increased energy just goes into agitation rather than being a goal-directed activity. We may see a person who's pacing about or wringing their hands or talking rapidly in a fashion that's hard to make sense of. Besides those kinds of symptoms, a manic episode has at least 4 other symptom clusters. There's less need for sleep. That is, not only does the person sleep less, but they don't feel tired and fatigued sometimes for days at a time. They're usually more talkative, and they may talk more rapidly and louder than usual. Often there's excessive spending or other kinds of risk-taking behavior. People may spend more on themselves or on others. They may take risks by gambling, driving fast, perhaps having sexual activity that's not typical for them or that might be risky, perhaps abusing drugs, which is out of their usual behavior pattern. Often there's grandiosity. That means somebody has kind of a superlative aspect that they're talking about in their behavior. For example, I had one patient who told me he had invented a perpetual motion machine. Another patient came up to me once and said that they were the Messiah. Those would be considered grandiose delusions. Sometimes there's a flight of ideas where the person's ideas jump rapidly from one to another, often so quickly that it's hard to follow them and make sense of it. And they have increased distractibility. They can be distracted by some item in the environment and suddenly go off on a tangent about that. And mania may have symptoms like hearing voices or seeing visions or having delusional thoughts like the grandiose delusions I referred to before. And the flip side is major depression. Here we're talking about people who have a period, has to be by definition at least 2 weeks long, in which their mood is pervasively sad or empty most of the time, pretty much every day. Often there's a pervasive loss of interest or pleasure. Maybe they used to enjoy getting out and fishing, but you can't ignite any interest for them in doing such an activity now when they're depressed. Often there's significant weight loss or weight gain or a change in appetite, either a loss of appetite or sometimes an increase in appetite. In depression, there's also insomnia, but usually people feel tired and fatigued and wish that they were able to sleep more. Some people do sleep more throughout the day and have excessive sleep during their depression periods. Psychomotor agitation, we made a little reference to that before, where people may be moving about rapidly, often in a kind of aimless fashion. Maybe they're pacing or wringing their hands or talking rapidly. Or sometimes they show psychomotor retardation. Now that's where people are way slowed down. Often there's a long latency when you ask them a question before they answer. They may talk more slowly and move more slowly. Fatigue is often a symptom. Feelings of worthlessness or guilt. Sometimes people who've done a fine job as a parent, a spouse, or in their workplace may feel unrealistically guilty and feel as though they've let people down or haven't been pulling their weight when in fact they have. Many times there's trouble concentrating. It may be hard to read or even watch a TV show, or excessive indecisiveness. I can remember a case once where I was talking with a very depressed patient and trying to get them to sign into the hospital, and they would pick up a pen and hold it for a few moments and then look at the paperwork and put the pen down again. And their family and I would urge them to give it a try, and they'd pick up the pen again and repeat. And this went on for about an hour before this very indecisive person finally signed into the hospital. And in depression, there can be thoughts of death or suicide, not usually just a fear of death, but sometimes a wish to have it all over with, or actual thoughts about suicide or planning suicide. And as I say, to be by definition a major depression episode, it has to last 2 weeks. Our previous manic symptoms have to last a full week to be considered a manic episode. And a hypomanic episode has many of those same symptoms that we talked about in depression, except in hypomania, there's never hallucinations or delusions, and people aren't severely ill enough that they need to go into the hospital. And by definition, a hypomanic episode has to last at least 4 days. So when we talk about bipolar 1 disorder, this means someone who's had at least one full-blown manic episode. And they may or may not have had an episode of major depression. In fact, most do have major depression and probably more minor depressive episodes, but occasionally you'll see someone who only has manic episodes or hypomanic episodes. Bipolar 2 is defined as someone who's had episodes of hypomania and also episodes of major depression. And now there are many people who have some of these symptoms but kind of fall between the cracks. They don't quite meet all the criteria. Maybe they've had major depression episodes, but they just had hypomanic symptoms for 2 or 3 days, not the full 4 days. Or maybe they just had 1 or 2 such symptoms. And so those people are what we might call on the bipolar mood disorder spectrum. And another more defined disorder within that spectrum is cyclothymic disorder. Here people have mood swings that involve milder depression and high episodes. It has to extend for most of the time for 2 years, and they can't have an episode of normal mood for more than 2 months during those 2-year span. We have to differentiate bipolar disorder from other disorders that may bear a resemblance. Sometimes we'll see somebody that's maybe in their late adolescence, early 20s, who comes into the hospital, say, with an episode of acute psychosis. They're hearing voices, they're agitated, they are not sleeping much. And many times it can be hard to tell in that acute psychosis whether they have a bipolar disorder with a psychotic mania or if it's an initial episode of schizophrenia. Usually we can tell the difference over time. Typically people with bipolar mood disorder will get better. Their mood will come back to neutral. They will no longer have trouble with hearing voices or delusional thoughts as they come back to neutral, and they'll be able to pick up at least moderately well with some of their previous schooling or vocational activities and social relationships. Many times with schizophrenia, we'll see someone who has a persisting problem with hallucinations and delusions, and oftentimes with schizophrenia, folks will become more socially withdrawn and avoidant, and over time they're less likely to continue to succeed in the workplace and at school and in some of their social relationships. Major depressive disorder is often what people get misdiagnosed as who have bipolar disorder, because most people will come to treatment more when they're depressed, and typically people have more days in depression than they do manic or hypomanic. Say somebody has these major depressive episodes and maybe they just have 3-4 days when they have a hypomanic mood right before they get depressed. They may not really even recognize that as part of their illness. And many times their treating professionals may not recognize that either unless they really dig for that. Attention deficit hyperactivity disorder might share many symptoms with someone who's in a manic or hypomanic mood. They might be physically more hyperactive, they might be talking more rapidly, they might be more impulsive, more distractible, more irritable. Here again, the picture over time helps us to differentiate these. Attention deficit hyperactivity disorder, ADHD, typically begins in childhood, and it's more of a chronic problem, the physical hyperactivity and the distractibility and trouble concentrating. Whereas with bipolar disorder, when somebody's in a manic episode, they may not be able to concentrate and focus well, but when they come back to neutral, they're able to focus much better and concentrate. Or when they're depressed, maybe they're very slowed down, they're not moving so rapidly. So with bipolar disorder, these hyperactivity symptoms and impulsivity are usually an episodic phenomenon where they're more chronic with ADHD. And perhaps 50% of folks that were diagnosed with ADHD in childhood will still meet that criteria as adults. And to make matters more complicated, sometimes we'll see folks who have both ADHD and bipolar disorder. Borderline personality disorder. What is a personality disorder is kind of a long-standing pattern of dysfunction in the way people relate to themselves and relate to others. In borderline personality disorder, people are often hypersensitive to rejection or abandonment, and such a episode of abandonment or a threat of that may cause them to get depressed. Sometimes they might be very rageful. Sometimes they might be self-destructive toward themselves. Often there's a very intense but unstable pattern of relationships with those close to them. So often we do see rapid changes, often in a matter of hours, from feeling good to feeling depressed when they perceive their significant other rejecting them. And that's different from what we usually see with bipolar mood disorder. Usually these mood episodes last much longer. The depression may last many days, sometimes weeks or months, and mania can last for also many days, weeks, or occasionally months. Where with borderline personality disorder, we're seeing mood changes on often a daily basis. And borderline personality disorder also, people usually have a history of some type of childhood abuse. With bipolar disorder, that's more in the range of 20 to 30% of folks might have that history. And borderline personality disorder, 60 to 70% of such folks often engage in some kind of self-harm behavior, frequently cutting or burning. And we don't see that nearly so often with bipolar disorder. This is rather than being suicidal, it's a sort of self-harm that makes the person with borderline personality, temporarily feel better. Schizoaffective disorder has aspects both of schizophrenia and bipolar disorder. There's a bipolar form where people have moods that go up and down, and there's a depressive form where they just have episodes with all the criteria of major depression. The difference is that in schizoaffective disorder, there is a persistence of some kind of psychotic symptoms like hearing voices or having delusional thoughts that persists after their mood comes back to normal or neutral. Whereas with bipolar disorder, when their mood comes back to neutral, the hallucinations and delusional thoughts will go away. How frequent is bipolar disorder? Well, in the United States, bipolar 1 and 2 together form about 1.5% of the population. And the other bipolar spectrum disorder is about 1.4%. That bipolar spectrum, again, would include things like cyclothymic disorder or folks that have recurring major depressions, but maybe they only have a couple days of hypomanic symptoms, not enough to qualify them as having a full-blown bipolar II disorder. So in the U.S., that's around 2.9% or about 10 million persons, so quite a sizable number, really. And worldwide, certainly over 100 million persons worldwide that have a form of bipolar disorder. What is the course of bipolar disorder over time? Well, the typical onset is in the late teens or the 20s, but sometimes we'll see even preteen youngsters who are clearly bipolar, and sometimes we'll see people in their 70s having a first manic episode. So it can be variable. One rather famous study found that there was a long delay in diagnosis, typically, of on average about 8 years from when a person with bipolar disorder first made contact with a mental health professional or other health professional, and when they were ultimately diagnosed as having a bipolar disorder. And some of that delay is, as I made reference before, we'll see the depression parts of their disorder, but sometimes the hypomanic or manic parts are hidden because they're so brief, or people don't even think about them as being an illness, because the subjective feeling may be to feel really pretty good during a hypomanic episode. Early episodes of the bipolar disorder tend to be triggered. For example, postpartum is a high frequency time for this to begin, or sometimes a loss, a death, or a divorce or breakup might trigger an early episode of depression. Whereas later episodes might seem to come out of the blue, as though you started something going and it takes on a life of its own. That aspect of it has been referred to as kindling. And our German psychiatrist Emil Kraepelin, that we referred to before, who coined the term manic depression, he studied many patients over years and found that as they got older, in general, they tended to have more frequent episodes and more severe episodes. Well, that certainly doesn't have to be the case today, and that's one of the reasons why we recommend people get treatment, because it can help to head off this pattern of worsening of the disorder as one gets older. And of course, that doesn't happen with everyone, but it is a problem with many folks, especially if they don't get treatment to head that off. The long-term outcome of bipolar disorder can be broken down into thirds as a rule of thumb. 1/3 recover well from their mood episodes and are able to return to functioning well in their jobs and socially. Another third generally recover pretty well from the mood episodes, but continue to have some impairment that affects their jobs or affects their social interactions. Sometimes it's kind of a low-grade depression that may continue with some of them, or impairment with some of their concentration. So I've had, through my many years of practice, treated quite a few nurses, and some nurses, for example, with bipolar disorder might have previously been working in the intensive care unit, but sometimes they had to move to less stressful circumstances. Maybe they worked in a nursing home, or some even dropped out of nursing and did other things that were less intense than being an intensive care unit nurse, which is a very intense job, to be sure. Another third really have some pretty significant disability. They might not be able to continue working a full-time job. Sometimes they have trouble just managing their activities of daily living, for example, remembering and taking their medications. They might need to move in with a relative or might even need to go to an adult foster care home to get that extra help and support. What causes bipolar disorder? Well, we can have two possibilities, genetics being one, and the environment, that is the things that happen biologically, psychologically, socially to an individual after conception. For many years, it was noted that there were family patterns to bipolar disorder, that is, that it tended to run in families. And then back in the 20th century, there were a number of twin studies where they looked at pairs of twins, and they'd look at one pair of twins that were identical twins. They had 100% of the same genes, and they'd also look at fraternal twins who have about 50% of the same genes, just as any brother and sister would, for example. Well, when they found one bipolar twin, they found that their identical twin was about 40% likely to also have a bipolar disorder. When they looked at fraternal twins, they found that the twin of a bipolar individual was about 5% likely to have a bipolar mood disorder. So this confirmed that there were very strong genetic factors behind bipolar disorder. Nowadays, of course, the search is on for the actual genes that can cause bipolar disorder. You know, some disorders out there like, sickle cell anemia or Huntington's disease really have just one gene that causes the problem. Huntington's disease, of course, was what Woody Guthrie, the famous folk singer, had. But bipolar disorder, as is the case with most psychiatric disorders, is caused by multiple genes, at least a dozen, possibly as many as 24 genes that play a role in causing bipolar disorder. And if you have any two unrelated bipolar individuals, they're likely to have a different set of these genes that tend to cause bipolar disorder. Another interesting finding from our recent years as the genetic basis of bipolar disorder is investigated is that some of these so-called bipolar genes, the ones that'll push an individual toward a bipolar outcome, also are there for substance abuse disorders and anxiety disorders, for ADHD, for autism, and for many of these genes are also in unipolar depression. So this is one of the reasons that people with bipolar disorder have a higher frequency of substance abuse and anxiety disorders and ADHD, because they already have several of these genes. If they're bipolar, their likelihood of having these other disorders is increased. So if, say, one parent has a bipolar disorder, their child has about a particular child would have about a 9% risk to be bipolar also. And interestingly, their risk to have a unipolar major depressive disorder is actually higher at 15%. How about on the environmental side? Well, we know that adverse childhood experiences play a role in many psychiatric disorders. What do we mean by ACEs, or adverse childhood experiences? Well, this can include physical or sexual abuse or neglect, a severe illness in a child, a parental death or divorce or other separation, family economic adversity, such as food insecurity or shelter insecurity, having a parent with a major mental illness or with a substance use disorder, with a criminality such that they've spent time in prison, or a parent with violence such that it gets inflicted on the child or witnessed by the child. All of these are considered adverse childhood experiences. And the effect of these adverse childhood experiences on bipolar disorder, we don't really have good evidence that these things actually can cause bipolar disorder, but rather they make the course of bipolar disorder worse or rougher. There's an increased number of episodes, increased severity of episodes, an increased tendency towards suicidality and towards psychosis, an increased incidence of substance abuse. There tends to be an earlier onset of the bipolar disorder and an increase of rapid cycling. Rapid cycling refers to when we have 4 or more mood episodes over a course of 1 year. The mood episodes being like a manic and a depressed and another manic and another depressed episode, all in the course of a year. And rapid cycling usually tends to be harder to treat than bipolar disorder without rapid cycling. So what can act as triggers for mania? Well, sleep deprivation is a very big one, and sometimes these other triggers that I mentioned may even act through sleep deprivation. Sometimes exciting events like a new job or a new relationship might get somebody jazzed up and might bring on a manic or hypomanic episode. A postpartum time is a very high frequency time for a manic episode. There are enormous rapid changes in our hormones during the postpartum period. A sudden drop in progesterone and increase in oxytocin, and plus there's often sleep deprivation and the psychological stress of suddenly being responsible for another human being. So lots of stressors there. Some substances may cause mania or trigger mania. Stimulants, prescribed ones like Ritalin or Adderall, or street drugs like cocaine or meth. Steroids like cortisone, or the androgen type steroids that people take to build their muscles when they're weightlifting. Those things can trigger a manic episode in a bipolar person. Sometimes taking an antidepressant without taking a mood stabilizer along with it can bring on a manic episode. And depression, too, has its triggers, loss being a big one, a death or the end of a relationship. The postpartum period also brings on many episodes of depression, both in bipolar persons and those without it. Certainly the postpartum depression or the postpartum blues is a very common phenomenon. Some substances can bring on depression: alcohol, opioids, some blood pressure medications like Reserpine. Those can act as triggers. Well, let's talk about how we can improve mood stability. And it turns out that many behaviors which are actually generally health-promoting behaviors can also improve mood stability, that is, reduce a tendency to slip into manic or depressed episodes. So we're going to talk about 5 areas there: sleep, exercise, diet, avoidance of substance usage, and healthy socialization. What are some good sleep promoters? Well, it's good to sleep in a cool, dark room. Why cool? Well, actually, our body temperature tends to drop a bit as we move from wakefulness into sleep. So a somewhat cool room can enhance that. It's good to avoid caffeine and other stimulants in the late in the day, in the late afternoon or evening, or even some other types of stimulation, maybe watching an exciting basketball game, better to watch golf perhaps. It's good to have regular times for going to sleep and especially arising, especially our awakening times tends to set our internal biological clock. And so one strategy for improving mood is to try to get some regularity with your sleeping and rising times. And people often recommend using the bed only for sleep or sex. If you tend to use it a lot, watching TV or reading, it's possible that you may unconsciously stop associating the bed with sleep, and it may be more difficult for going to bed to bring on sleepiness. It's good to develop some types of relaxation skills if you do feel keyed up. Sometimes these may help at bedtime. There's relaxing imagery skills, or what's called Jacobson's progressive relaxation, where you tense and relax different muscle groups. I actually use a kind of brief form of that sometimes. If my dog gets me up in the middle of the night, I have to go downstairs and let him outside and get a blast of cold air and various things. So this seems to help get you back to sleep. And also, as you're doing these activities, the progressive relaxation or relaxing imagery, such as imagining you're floating in an inner tube on a wavy day at the beach. Those things also act as substitutes for worrisome thoughts. It's hard to just tell yourself, well, don't think about worries when you're trying to sleep. It's easier sometimes to substitute a different, more calming thought. So insomnia can be both a warning of an oncoming episode of mania or depression, or it can be a trigger. It's certainly good for persons with bipolar disorder to make note of what kinds of symptoms might herald the beginning of an episode. Sometimes insomnia may be one. And so that when those kinds of symptoms repeat, you can reach out for additional help from your providers, or let your family or friends know that you might be starting to move into an episode. And insomnia itself, or sleep deprivation, can be a trigger for mania. Say somebody, a college student, stays up all night to study for an exam, and then the next day there's a big party because indeed they did well on the exam, and so they get 2 nights of sleep deprivation. Something like that could act as a trigger to bring on especially a manic or hypomanic episode. Well, we've talked about sleep. Let's talk a little bit about exercise. Exercise has many benefits for our general health, especially, our muscles and joints, our cardiovascular health. And I don't know that there are studies that precisely define, what is the best exercise for improving mood stability for bipolar disorder. So we can try to use the World Health Organization exercise guidelines as a guide there. They recommend for adults 150 minutes per week of moderate exercise. That would be things like brisk walking, doubles tennis, or dancing. Or 75 minutes per week of vigorous exercise like jogging or singles tennis, maybe swimming. And muscle strengthening exercises twice a week also. For folks who are older, beyond 65, I think the World Health Organization and the American Medical Association recommend 150 minutes of an activity throughout the week. This may be an activity that helps with muscle strengthening and balance, and some with endurance. Could be something like Tai Chi or dancing or just walking. But this pattern of exercising can certainly help. We know it has very direct antidepressant effects. There have been some studies that showed exercise having as strong an antidepressant effect as medications for many people. But using it as a preventative, mood stabilizing behavior. Well, we've talked about sleep and exercise. How about a bipolar diet? Well, what should a bipolar diet accomplish? We want to help to maintain mood stability, and we also want to prevent metabolic problems like diabetes or high cholesterol and triglycerides and obesity, and the things that tend to come along with those problems, which is heart disease, heart attacks and strokes, cardiovascular disease. Because unfortunately, there's a higher incidence of cardiovascular disease in bipolar persons, and even a slight reduction in their life expectancy because of cardiovascular disease. So we want a diet that's going to address that problem too. The so-called Western diet in the United States and parts of Western Europe consists of pizza and chips, white bread, sugar-flavored drinks like sodas, beer, processed meats like hot dogs and bacon and sausage. It's high in saturated fats and sugar and refined carbohydrates, high in sodium and nitrates. In contrast, the Mediterranean diet, which has been found to help with cardiovascular disease, has more fish and shellfish and less red meat, has fresh fruits and vegetables and whole grains, fewer processed foods, and uses healthier unsaturated fats like canola oil or olive oil rather than butter and margarine. The Mediterranean diet, of course, is named for countries that tend to surround the Mediterranean Sea. When researchers have studied the eating patterns of persons with bipolar disorder, they've found that they tend to drift toward that Western diet that I mentioned. They tend to eat alone. They often eat one meal per day. They may have trouble obtaining food and cooking it, perhaps for economic reasons or just because of their location. They have higher rates of obesity, of diabetes, of hyperlipidemia, which means high cholesterol and or triglycerides, and consequently higher rates of heart disease. Researchers like to study the incidence of different disorders around the world. So in the process of studying the incidence of depression and bipolar mood disorder, they came on an interesting finding. Countries that had high ocean fish consumption have lower rates of depression and bipolar mood disorder. For example, Iceland and Taiwan have lower rates than Germany and Switzerland, which are landlocked, and they have a lower tendency to eat these ocean fish. And at least some of the reason why these ocean fish had this mood stabilizing effect was omega-3 fatty acids. These are building blocks of our brains and nervous systems. They're a substance which our bodies can't manufacture, but we have to obtain from external sources. They're found in cod and salmon and scallops in high density. They're found in walnuts, flax, seeds, and basil for you vegetarians out there. And they also have anti-inflammatory effects. They may help with autoimmune disorders like rheumatoid arthritis to some degree. And there have been at least 5 studies that found that adding these omega-3 fatty acids to an ongoing medication regimen actually helped bipolar folks gain more mood stability and had less tendency to relapse into mania or depression. What is the MIND diet? It stands for Mediterranean-Intervention for Neurodegenerative Delay. There's a real mouthful for you. We'll just call it the MIND diet. But it's a combination of that Mediterranean diet we referred to before and the DASH diet, which is a dietary adaptation to stop hypertension. The DASH diet's been around for a long time. It emphasizes lower sodium and higher potassium and magnesium via eating lots of fresh fruits and vegetables and whole grains, and it also minimizes the processed foods that tend to have a lot of high sodium content. So the MIND diet was kind of a combination of this Mediterranean and DASH diet. And when they took 2 groups of older people who had a bit of early cognitive difficulty, that is, they were starting to have some memory difficulties, and one group continued as usual and the other group got the MIND diet, lo and behold, over a period of years, the group on the MIND diet had fewer individuals who slipped into a full-blown Alzheimer's dementia. That's why they call it an intervention for neurodegenerative delay. So it is kind of a brain-supporting, brain-healthy diet in that sense. And briefly, the MIND diet involves leafy green vegetables like lettuce, spinach, kale, other vegetables, carrots and cucumbers, berries, nuts and beans, olive oil, fish and poultry, whole grains, and wine in moderation. And by moderation, I would say with what we know currently about alcohol, probably no more than 2 or 3 glasses a week. And in the MIND diet, you tend to avoid red meat. You avoid stick butter and margarines. You avoid pastries and sweets and cheese. You avoid fried and fast food. So trying to move one's diet closer to this MIND diet may bring many health benefits, including some better mood stability, especially when you include, the foods that are high in the omega-3 fatty acids like the fish and ocean fish and scallops and walnuts, flax, and basil. And I realize it's very hard to be strict with these diets, but sometimes people may have a time they get a juicy cheeseburger or a steak, or they have a piece of a rich cake at somebody's birthday. It's not a totally all or nothing thing. So we've talked about diet, exercise, and sleep. What can we say about substance abuse in bipolar disorder? Well, when they've looked at folks that do abuse substances of various kinds and those that don't, they find that those bipolar people that abuse substances have more hospitalizations, more suicides and suicide attempts, more rapid cycling, and again, that's where you have 4 or more episodes in a year of high mood, low mood, high mood, low mood, which becomes more difficult to control. They have more loss of jobs and relationships, and they have mood episodes that don't respond as readily to treatment. And I should say this has also been, when they've looked at folks with bipolar disorder who had a substance abuse problem, and then they were able to curtail the substance abuse problem in the control group, and those folks did much better, while the ones who continued to abuse the substances had more of these negative outcomes. People with bipolar disorder do tend to abuse substances more often than the general public. These statistics are from a Stanley Foundation study that was published, I believe, in 2001, where they looked at hundreds of folks with bipolar disorder and found that 33% of them abused alcohol, 16% abused marijuana, 9% abused various stimulants, 9% abused cocaine, and 7% abused opiates. Perhaps if we looked at this today, some of those figures might be a little different, but pretty much in line. And I have to say, even though in Michigan marijuana has been legalized, when we look at scientific studies where they follow a group that smokes marijuana fairly heavily and a group that does not, they do see all those negative outcomes that we saw 2 slides back, with more hospitalizations, more suicides, more loss of jobs, etc., in the group that smokes marijuana. Perhaps someday we'll isolate certain chemicals from the scores and scores of chemicals that are in marijuana that may help certain aspects of bipolar disorder. But as of right now, I don't think we have good scientific evidence that that's the case. Certainly you see individuals who feel that marijuana helps them calm down and sleep, and they may believe that it benefits their bipolar disorder, but so far we don't have scientific evidence to really back that up. Social support systems are another healthy behavior that can help stabilize mood. Bipolar patients tend to do best with low expressed emotion. By that I mean, rather than somebody who's shouting and ragingly angry, somebody that can express their anger or disappointment in a calmer fashion and still maintain the message that, we care about you and we value you, and something that's supportive of their self-esteem. So we may need to avoid people who are very critical and undermine your self-esteem, or smothering relationships like a helicopter parent that won't allow somebody to be more independent. Certainly many folks with bipolar disorder have periods in their life where they need to have a family or friend intervene and maybe take a little more control in their life perhaps when they have to go into the hospital or they're having a whole lot of symptoms. But in healthy relationships, people are able to then back off some of that additional control when someone's doing better, and allow them to be more independent and help them to become the best person that they can be. And then this social support system might be family, it might be friends, might be a church or another organization. For some folks, it might be a clubhouse through the community mental health, where they get a lot of social support. Nowadays, it might even be from some online entities or friends. And wanted to kind of close off with this slide, 8 steps towards stability. If you have bipolar disorder, accept the disorder. If there's some question whether you have it, get a second expert opinion if need be. Find knowledgeable, compatible providers. It's really important that people are able to work with and trust their providers. Just that aspect of rapport sometimes does as much good as medications or other interventions. It's important to closely follow your medication regimen and to get labs when they're needed. In this way, you can work with your provider to better really know what a particular medication is doing for you. If they think a particular medicine isn't working that they prescribed 4 weeks ago, but you're only taking it once out of every 3 days, that's really not the conclusion that needs to be drawn. So to know that things are working well, it's good to closely follow the prescribed medicines and the laboratories. And as we talked about, it's good to avoid substance abuse for all the reasons we discussed. And to pursue a healthy lifestyle in diet, approximating that MIND diet, getting good sleep with regular times to sleep and arise, getting, if you're in your adult years, 150 minutes per week, if possible, of moderate exercise, and to seek out healthy social support systems. It's good to learn about bipolar disorder. Programs like this or other programs and books that can help you learn about bipolar disorder are important. It's good to select a family member or friend who knows you have bipolar disorder and who can help you out when that's needed. Perhaps you're having a difficult time and need to get a ride into the emergency room or into the clinic to see a provider. And it's good to have a contingency plan when things get rough. If you're having a really depressed period with suicidal thinking, to have the number to reach your provider or a suicide hotline or the number of the emergency room to rapidly seek help, because it's better to make a little list like this when you're feeling good, because when you're feeling real down and depressed, it can be very difficult to look up some numbers and know where they are. And it's good to have people you can call on then too, who can help you out or take you into the hospital or clinic if need be, or stay with you. Well, my name again is Dr. Robert Fawcett, a local person from Bear Creek Township up in Emmett County. And I hope you've enjoyed this presentation, and I hope you've learned some valuable things from this. So without further ado, I'll sign off at this point. Thank you.